Uh, uh, this is my pleasure to, start this session with our government representative from Bangladesh, Dr. Muhiuddin Osmani, and he is the Chief of Planning Wings of the Ministry of Health and Family Welfare. He's also keen interest about the urban health, and he has been working in this ministry in the planning wing for a long time. I also like to welcome David Vlahov, by whom I introduced with this ICUH, and I should say that his presence in this event is give us some sort of way forward how we can take this conference outcome in the upcoming Sustainable Development Goal and other development activities. I have a small presentation. I thought that it would be good to share with you some information. You all know that this International Society for Urban Health established in 2002, and New York Academy of Medicine working as a secretariat. And the mission of this association to establish as an excellent organization which can accommodate different discipline practitioners across different sectors, representative from the civil society, academician from different parts of the world, to advancing the urban health and urban equity in urban setting worldwide. As you know that last year in Bangladesh we organized, my organization Eminence Associates organized this ICUH 2015. And before that, it was in different part of the world, and we were the second, developing countries after the Kenya in 2009 who organized this conference. Most of the time in USA, Netherlands, then Canada, and other part of the developed world, this conference was organized. If you look at the themes of different times this conference organized, then it covers the global urban health agenda. That is what is the priority and infrastructure we need. Then it also covered the achieving social justice in the urban communities, then population mobility and its effect on the urban health, then harnessing the power of the technology to achieve the behavioral change and improve health, knowledge integration, successful intervention in urban health, meet the urban health needs through the innovative research policies and intervention, then good governance for the urban cities, urban health action towards the equity, cross-boundaries partnership for the global urban health, and last year the agenda was the urban health for the sustainable future, the post-2015 agenda. As you know that the Sustainable Development Goal is going to start from this coming year, and we have already got 17 different goals with several indicators. In that perspective, last year conference focused on these Sustainable Development Goal issues, and the main thematic areas and the Dhaka statement, we identified that we need to develop and implement a national level health policy that will integrate the planning of rural and urban areas, because most of the developing countries, interventions and resources used to go to the rural areas. So that integration we identified is very important, and recognize the importance of the city and local level data and action to advance urban health. Second was support strong and effective governance to promote the urban health, including the clear roles of the cities and local government, a strong public health infrastructure that can work in partnership with other sectors to prevent and mitigate the potential risks and benefit of the health of policies, programs, and investment across sector. Establish and track the national level targets and indicators that reflect the progress towards the urban health and health equity. And you know that this year, this San Francisco meetings, its themes, global initiative advancing the urban health, the place-based action to prevent the disease and promote the health in cities, lesson learned from the local middle-income countries for advancing a culture of the health in the United States, then evidence for the action in policy and programs for the urban health. The point is that this conference outcome, ICUH like to take it forwards to work on the upcoming Sustainable Development Goal. As you know that we have 17 goals, and if we segregated these 17 goals into the people's-oriented goals, that is the first 7 goals, then hard economic goals, then 8 to 12 goals, which include the habitat 2, then environmental and climate change goal, that is 3 goals, that is environment, climate change, and ocean related, then factor to achieve the goals, that is 2 goals, that is partnership as well as the peace, peaceful environment. I think that, if you consider this goal number 11, that is the habitat, at this moment we have 50% of the population in urban areas, and which is going to, increase rapidly. And if we focus this goal number 11 and put it inside the goal number 17 as a partnership with the different sector, different actors for achieving or making the, some sort of their target or their indicators as an urban perspective too, not only the rural perspective or other perspective, then you can have a better outcome for the goal number 3. If I segregate it again, this goal number 3 can have these direct indicators with the goal number 1, 2, 4, 6, 7, 8, like poverty reduction, food, then education, then women empowerment, other, then goal 5, 9, 10, 12, 13, and 14, which can be an, indirect indicators where we'll find that, partnership, infrastructure development, others. Then influencing factors is 15 and 16 number goal. Then we can have a better, SDG 3. As you know that, the process we are following for this, agenda of SDGs, then 2030 agenda, that is documents come up, and that is now high-level political forum is going to, accredit it and discussion about this thing and taking the final decision in July 11 to 20, 2016. And in this high-level political forum, all the government, UN system, other intergovernmental agencies, major groups, and stakeholders are involved. Entities interested in organizations can organize the side event during this time, and proposal last date is 1st June 2016. The application for voluntarily national reviews for this 2030 agenda just recently finished. It was in 29 February 2016. If you look at that, which nation already given their name to act as a voluntary nation to review this agenda, we found that 22 nations where China, Colombia, Egypt, Finland, France, Georgia, Mexico, Morocco, Norway, Philippines, Korea, Sierra Leone, Switzerland, Turkey, Venezuela. We need to actually make some sort of relationship with this country's government and advocate with them. Then they should also talk about these urban health issues when they will do the review and this high-level political meeting in July. These SDGs also have nine major groups, which includes women group, children and youth, indigenous group, NGOs group, local authorities, workers, trade unions, business, scientific group, and farmer group. Within this NGO group, I think that ICUH need to make a link up with them to forward our agenda. And we found that this NGO group has like three organizations called European Environmental Bureau, World Alliance for Citizens Participation, and Consumer International. Unfortunately, the World Alliance for Citizens Participation, Jeff Hoofens, he is from United States, and other two members, we need to communicate with them and interpersonally advocate them for urban health issues. So this conference, as it's a joint program of ICUH and Association of American Geography, I think we need to act now. Thank you so much. Now I'd like to request David to come.
So I'm David Vlahov, and I'm now at the University of California, San Francisco. And so welcome to the city. And it is known as 49 square miles surrounded by reality. It's a magic city to work in, and I think it's one of the most progressives in it. And if you've seen some of the presentations, Jason Coburn, for example, you can see the energy that's around the Bay Area. I was at the New York Academy of Medicine, and Dr. Jo Boufford, I think, has been modest about the role she has had and continues to have at the New York Academy in terms of really being the spark of the International Society for Urban Health. The society started out as a very small group of people that conducted a meeting, held a conference in Toronto. And at that time, as the Center for Urban Health, for us, that meant in the United States and Canada, there are areas of concentrated disadvantage within cities that need attention, right? There are disparities in health. And so how was it that we were going to look at that and bring together researchers, so primarily an academic enterprise, if you will. And in the very first meeting, we had about 125 people overall, and they came from around North America, basically. But there were 6 people who came from outside, from Africa and Asia. And we were listening to them and saying, you know what, we're really being very narrow in terms of how we're thinking about urban health. And it was really at the second conference that we brought together, how do we develop a conceptual approach? How is it that we can develop the vocabulary that would be bringing us together and also expanding on that? And so that went on to look at not only the individual factors, but social and physical environment, and then also looking at what influences those and thinking about municipal and national perspectives. People, and in that meeting it was about 330 people that came, and from maybe 12 countries overall. And there was a lot of energy that came out from that meeting. One was a small group of people who were starting to have educational programs about urban health. And there was also new partnerships that were being created from this. And if you'll notice, there were a few books that were being written about this to organize the thinking. This then led to a meeting in Boston, and the meeting in Boston really built on what we were learning in the first 2 meetings, which was this is not just areas of concentrated disadvantage within developed countries, but truly a global phenomenon. And that was really an educational experience and expanding what it was that we needed to do. Themes after that really built on different elements. The one in Toronto after, the second one, really looked at, well, that's great that we're a bunch of academics that are thinking about individual and community health, but where's the community component? And so let's be able to talk about community engagement. The next meeting talking about, you know, the world is developing information technology. How is it that we should be optimizing that in cities? The next meeting after that is so relevant right now, and it was really looking at mobility and cultures. And the meeting was in Amsterdam, and looking at, you know, at that time, people from the Middle East moving into Europe as one of the examples. And some of the lessons that we learned there were discussed, and some of the people that were at the conference are now dealing with the challenges that are happening in Europe right now. So again, relevance as we're going through. Vancouver, let's start talking about what are best practices. What is it that we know and can be sharing with others, even though the circumstances are different in each country and each city. How is it that we can start to share ideas? There, again, is continuing movement as we looked at the Year of Urban Health from the World Health Organization. We had a meeting in New York City that brought together people who were involved with developing the materials from that year. And that was very exciting in that we had a reception at the United Nations itself. And again, it was really showing how the organization, the International Society for Urban Health, moved from an academic perspective to look at what is the community relationships and engagement. And in Nairobi, we had talked about and brought together mayors. How is it that you look at governance in cities and all the kinds of partnerships? We moved away from just thinking about what's the kind of research that academics need to do? What are the different disciplines? You know, urban health and public health, for example, and the many others, political science and sociology. How do we bring together these groups to really develop a common shared enthusiasm, but also crossover with each other? So that, for us, was the next direction. We had really started thinking about these levels. Meetings since then have really taken on really very international, very global kinds of themes, looking at the importance of governance overall and how that's going to be the way to move forward. You know, we can talk about urban and what are the kinds of programs that we can set up, but programs get funding and then funding ends. Program helps certain elements of a population, perhaps, and again, how is it that we're going to really make change that's going to be meaningful? And it's policy. How is it that you frame what it is that needs to be done that can help to set up those programs? And I think what we're looking at here with the Sustainable Development Goals is working with the WHO, working with the United Nations, working with each other at the level of academics, but also community, bringing in governance, now bringing in industry as well, business, private partnerships. And I am so enthusiastic that having been there at the beginning and seeing how the organization has grown, how the many different kinds of people have come together, how we've gone from just being scholarly to being advocates for urban health is enthusiasm I can't even begin to tell you. So as we're starting this conference, this session of the conference, I really want to tell you from a beginner's perspective that you're in the right place. You're in the right place. And you're going to see much more that comes down the line. So anyway, thank you for being here, and let's get on with the program. Thank you.
Thank you, David. Now, Dr. Muhiuddin Osmani, Chief of the Planning Wing, Ministry of Health and Family Welfare, Government of the People's Republic of Bangladesh.
Distinguished discussion participant, inspiring audience, ladies and gentlemen, very good morning from Ministry of Health and Family Welfare, Bangladesh. I am Dr. Muhiuddin Osmani. I represent the Ministry of Bangladesh to participate in this conference. First, I would like to thank all the organizer, sponsor, and partner for this excellent international conference on the urban health. There are academics, donor agency, public officer, private sector representative, and civil society all present to contribute to a global effort for sustainable development in urban health as part of sustainable SDG, Sustainable Development Goals. So I feel myself fortunate to be part of this effort. As you know, Bangladesh received high appreciation for being in track with the achievement of the Millennium Development Goal by 2015, and on track now, accordingly, we start our journey to achieve the objective of Sustainable Development Goal for our sustainable future. I am sure by adopting best practice, as we have learned from this experience of world-renowned specialists, it will be possible to achieve the goal for urban development with the support of our development partner and developed countries. So, as all of you know, that the 12th International Conference on Urban Health was organized in Dhaka in 2015, and the main outcome of that conference was Dhaka Statement that was adopted during the conference had intervention coherent with the urban health for a sustainable future. We acknowledge the Dhaka Statement and urge our partners to follow the activities as stated in the statement. I also assure from the Ministry of Health and Family Welfare of Bangladesh that we will give its best effort to achieve target of urban health care and development with effective intervention in urban setting and addressing urban governance. We give emphasis on making functional collaboration and cooperation among all the public sector actors in urban health activity and other ministry for an effective, coordinated, and synergistic urban health service delivery system, and also collaboration and cooperation between the public and private sector for urban health service delivery. Our government is very much committed to overcome any challenges and to improve the health and well-being of the population of the country, both urban and rural. So we have successfully come along so far, and I believe together we can successfully move forward also in making our planet a prosperous and beautiful one in reaching to the future we want. I wish this meeting will be a valuable contribution toward the agenda. I congratulate the organizers of this event International Society for Urban Health, ICUH, and American Association of Geographers. I would like to thank the sponsor for this conference, Novo Nordisk, Novartis, Wellcome Trust Foundation, Robert Wood Johnson Foundation, Gordon and Betty Moore Foundation, Kaiser Permanent, for their support for this conference. At the same time, I would like to give thanks to the sponsor who organized the last conference, that is Gate Foundation, USAID, CEDA, and ADB. We hope we'll work with all these partners for the betterment of urban health and development. I thank Joe Ivey, Boufford, President New York Academy of Medicine, and Dr. Shamim Talukder, President ICUH, for their kind invitation to me for this conference and their relentless support for the development of urban health. I personally very much interested about the development of urban health activity and improvement of the urban health service in Bangladesh, because in the survey it was shown that the urban health is still a bit lower than that of the rural health. So we have to work together. Thank you very much. Thank you. And welcome to Bangladesh if anybody wants to come to our country.
Now, Joe Boufford, President of New York Academy of Medicine and the key person of this conference. I'd like to hand over the session.
Good morning, everyone. It's my great pleasure to introduce our partners. And the reason we're taking a little bit of time on this is so that you know the reach and the connection that I think the partnerships that we've had bring to the International Society for Urban Health. So I'm going to start with Jose Siri, who's a research associate at the UN University Institute for Global Health, and he's going to tell you a little bit about his organization and how they connect to urban health.
Thanks, Joe. I haven't had a chance to put a picture of San Francisco up here, but I certainly will. So, dear friends and colleagues, on behalf of Anthony Capon, the director of the United Nations University International Institute for Global Health, it's my pleasure to welcome you and to thank you for your participation and your warm acceptance of us at this meeting. I think it's tremendous turnout at this meeting. It's a testament to the efforts of the International Society for Urban Health and its partners, and to the urgency of the urban health challenges that we face. But we live in a time when we've made great progress in human development. Global poverty has been decreasing, life expectancy has been increasing, health overall is better year by year. And yet we have unresolved challenges in urban health, and we face serious and growing threats to the environment that supports us. The ways that we design and live in our cities greatly impact not only our own well-being, but also the health of planetary systems. At a conference dedicated to health and place, I think it's incumbent upon us to consider the health of the place where we all live, and so to foster the health not only of today's urban dwellers, but of generations to come. A focus on planetary health will complement our efforts to resolve the many health challenges we face in cities. Over the past few days, we've heard about your important research and action in over and under nutrition, NCDs and infectious diseases, healthy environments and healthy minds, and so much more. All of these are things that we think about and work on at our institute. Hovering over almost all of these issues is the issue of equity for all urban dwellers, equity in access and opportunity in health. These are complex problems, and all too often we try to resolve them through approaches that oversimplify. That's one of the things that we work on a lot. We see a problem like obesity, and we know that obesity responds to physical activity. And so we design a policy to narrowly promote this goal. But the reality is that obesity is the result of an incredibly complex set of simultaneous influences that can amplify or resist policy efforts and often lead to unintended consequences. This complexity is why no country in the world has been able to reduce obesity in the last 30 years. And it's why we have to look for new ways of looking at old problems. An important part of this will be embracing systems approaches that allow us to understand how urban systems evolve and respond to decisions made in cities. This will require both developing and applying new analytical frameworks, and new ways of engaging and seeking out new partners. The need for systems thinking is an important reason why my institute is a co-sponsor of the International Council for Sciences Program on Urban Health based in Xiamen, China. And I encourage you to all engage with this program, Making for Urban Health. This is a moment of great opportunities. Last September, the nations of the world signed up to the 2030 Sustainable Development Agenda and a host of other global frameworks for development. For the first time, the urban is a central focus in all of these agreements. But there's still an urgent need to emphasize that health is the central aim of development. In particular, we need a new vision of health that embraces its social, ecological, and economic underpinnings and its strong connections with the environmental implications of development. This fall's UN Conference on Housing and Sustainable Urban Development, known as Habitat 3, will be an important place to promote this view of health, and I hope many of you will be there with us. And I'll just close by saying that we had a conference this year in January to promote health in Habitat 3, and I have some of the outcome documents here, so I'd love for you to take a look at them. Thank you very much.
I'm going to speak briefly to two additional partnerships that I wanted everyone to know about. One of them was mentioned by Jose, which is the ICUH Program on Urban Health and Wellbeing. This is one of 3 global programs. It's located at the Institute for Urban Environment in Xiamen, China, and Yongguan Zhu was here with us, had to leave before he could be here to greet you on behalf of this particular program. For those of you that are not aware of ICUH, it's a very important one. I think geographers are aware. One of the larger sections of the ICUH group are their global Congress of Geographers. And the mission is to really promote science and to make sure that scientists from around the world have access to the broader scientific environment. This is really a global organization of literally scores of professional associations, which by their association with ICUH open the opportunity for collaboration. The Urban Health and Wellbeing Program was established a little over 2 years ago, and we're connected with it along with the Inter-Academy Medical Panel to really look at how to promote a systems approach to complex urban problem solving and to support science and the advancement of research and science in systems approaches and modeling for complex problem solving. 2 concerns have been big ones in the evolution of this program. One is, what does a systems approach mean for science? And this means looking at the complex adaptive systems and developing more advanced scientific methods. The second question is also equally important, what does it mean for society? And the emphasis on co-creation of knowledge and well-being and engaging in action with communities is a theme that's very important in the work of this program. And finally, this is their website, and would encourage you to visit it, and again, a very important partner for ICUH. The next one, we were trying to avoid this, but it didn't quite work, sorry. Okay. The next one is another very important set of networks, the Inter-Academy Medical Panel. This is now called IAP Health and reflects a recent merger of all of the academies of medicine and science around the world. There are about 117 of them, mostly, actually all around the world. And this organization's goal is, this is the Medical Academy's goal, which started the partnership with ICUH and with ICUH, is to strengthen academies as a vehicle to provide evidence-based aid to governments in health and science policy. This is quite a cultural change for many academies of medicine and science, which generally have been honorific organizations, but not really engaging much in making a difference. And they're quite committed to doing that, and these academies around the world are really stepping up to this challenge through their recent merger with the idea that academies could begin to speak with one voice in terms of influencing global health and science policy. This is the executive committee of the IAMP, Professor Lai Meng Lui of the Malaysian Academy of Science and Professor Detlef Ganten of Germany, and you can see the representation of the executive committee worldwide and the the World Academy of Sciences, TWAS, is also a member of this group. This is a display of the distribution of the membership. It is quite global in nature, and actually the African academies are growing. There are, I think, 17 now instead of 12, which reflects the activity in that region. This is the distribution of the academies, and these are the programs that the IAMP is pursuing, and urban health has been a major program for the last couple of years through partnerships, and most directly in the next weeks and months, we expect to see, we have a working group forming of academies that have expressed interest in working on urban health, and many of them relate to the countries that Shamim mentioned that are actively involved in the SDGs and habitat. So part of our challenge is connecting these leaders in science and medicine with the leaders of their countries to begin to advocate for urban health. So this is their statement of joining. They're very pleased and will be committing to work with us on SDGs, especially 11 and 3, and as well as the Habitat final report. This is their contact. They're in Trieste, Italy, and our ICUH.org, very easy to look, or IAMP.org, easy to find. Okay, David. So let me just move from there. I also want to thank WHO Kobe Center. Alex Ross has been here. You heard him on Friday, and we're very delighted that they're working with us. We've been a long-time non-governmental partner, actually, for the urban health activities of WHO Kobe. And now let me acknowledge the critical sponsors of this conference that were mentioned by the minister and also by Shamim. Novo Nordisk, in its program on cities changing diabetes, you'll be able to hear from Niels Lund about their very ambitious program leading with cities and tackling a complex problem. He'll be speaking at the plenary towards the end of the afternoon. We thank them very much for their support. The Wellcome Trust has also provided support for this meeting, Claire Matterson and Sarah Moulton, and they have recently announced, I think they're probably a third of the people that are attending this meeting are waiting for their emails to go off or their phones to ring to see if they got the grant, but they've announced funding of a limited number of very high quality interdisciplinary research programs around the world with a focus on really understanding the drivers of health and well-being, and the two thematic areas they've selected are global food systems and urban health. The Gordon and Betty Moore Foundation, which is a local foundation, Janet Corrigan and Harvey Feinberg, who normally actually don't, as I talked to Janet, she said, we don't normally fund conferences, but we're beginning to be interested in the complexity of urban problem solving and the fact that it does link up a lot of the programs that we are developing, so we appreciate their support. Elsevier, Deirdre Dunn is here, and we're, I think, on the brink of a very important partnership for ISUH around the production of these conferences, so we're very excited and appreciate their support. And finally, before we have two live people here to tell you a little bit about their programs, Kaiser Permanente, which is certainly one of America's leading health systems serving 10 million members, and they have always been seriously promoting community benefit and the role of a healthcare delivery system in promoting health. So we thank Ray Baxter and Ben Chu for their support. So two other very important sponsors who are not presenting their programs later in the program, so we've given them a few minutes this morning to familiarize you with their activities. And the first speaker, their bios are in the program, so I'll just introduce them. Dr. Ann Aerts, who is the head of the Novartis Foundation since 2013, is going to give you an overview of the Novartis program, which is very centrally involved in prevention of cardiovascular disease in cities.
Thank you very much, Joe, and Mr. President, ladies and gentlemen, good morning. It's a great honor to be here today with you and learn from all your insights on urban health. So why would we like to focus on urban health in the Novartis Foundation? Simply because the scale of the global health challenge today is unprecedented. We have an unfinished agenda of the infectious diseases, mother and child health issues, the threat of emerging new diseases that we see every time over and over again. But at the other end of the crossroads, we see this rapid urbanization with increasing poverty and changing lifestyles, and with that, a rising epidemic of non-communicable diseases. So low and middle income countries face really a dual burden of disease, where in Africa that balance between infectious disease and non-communicable disease is still half-half. But in Asia, for example, the balance is already tipped over very much so in the sense of non-communicable diseases being responsible for 70 to 80% of all the morbidity and mortality in those countries. And the world still has to acknowledge that the majority of non-communicable diseases burden is in low and middle income countries. 4 out of 5 deaths, for example, occur in low and middle income countries, but only 2% of the overseas development aid has been going to this problem. All the other aid has been gone to infectious disease and mother and child health issues. On the other hand, low and middle income countries face health systems that are often very weak or insufficiently prepared, not in the least by the gap in the number of skilled human resources they have. As you see on this graph, the inequity in the number of population per doctors in the world is striking. So that's why we believe that to address this huge global challenge today in an urban setting, it requires not necessarily to deliver more innovation, but to innovate the delivery of services. And we have really no time to lose. And that's what the Novartis Foundation has chosen to focus on. So besides our work on the elimination of leprosy, where we are covering the last miles, the most difficult ones, our main focus is on pioneering new models of healthcare delivery in low and middle income urban settings. And we do that always in a very evidence-based way, because we belong to a company that is evidence-based by definition. So our work is very focused, but always a continuous cycle of evaluation, adaptation, and application. And we consider the pioneering of these new models of health service delivery as our R&D. Where our company is doing R&D to develop new therapeutic options, we want to develop new ways to deliver health services. And we like to learn, to test and learn and fail quickly, or succeed quickly. And then when it's successful as a new model, we will decide at a certain point to validate and scale it for impact. And within the Novartis Foundation, we chose to focus specifically on hypertension, the prime risk factor for cardiovascular disease, simply because it's the #1 killer in the world. 10 million people die every year of hypertension, and that's a mortality equivalent to all infectious diseases combined. How do we do that? Well, we specifically work with patients directly. We empower patients and their communities and their cities to take care and to take more responsibility in the management of their own health. So we are currently pioneering, for example, 2 of these models in Ghana, urban settings in Ghana, and now also in Ho Chi Minh City in Vietnam, where we have taken out of the health system certain activities that are overburdening health services, as you can imagine. So we maximize opportunities for screening, diagnosis, and also care outside the health service with non-traditional health providers. Like screening diagnosis can be done in Ghana in local chemical drug shops, or in Vietnam in post offices, social entrepreneurs selling soap or other things. So with that, obviously, we want to have an impact on the health of the urban populations that are the most underserved. But we can never do that alone. And in all of our programs, we work together with several types of partners. First of all, governments, but also non-governmental organizations, of course, and academics, and also the private sector. So in Ghana, for example, we work with FHI 360, but also with the Ghana Health Services. And the whole evaluation is done by the London School of Hygiene and Tropical Medicine together with the Ghana Public Health School. The same for Vietnam, the Hanoi School of Public Health, the Department of Health in Ho Chi Minh City is responsible for the implementation and evaluation of the activities. So we evaluate, measure, and share learnings across our partners constantly, so that we get to a sustainable model that we can scale and transfer to other contexts. But we saw while these two models we are currently implementing are still very much focused on the healthcare part on itself. And we see that we would have such a major, bigger impact on the health of the urban population if we would look at how to address the socioeconomic determinants. I don't have to tell you this because this is your expertise, obviously, but this is exactly what we are currently doing at the Novartis Foundation. We are setting up a new type of partnership with non-traditional health players, private sector partners from other industries to address these socioeconomic determinants, and we will do that in 3 other cities, one in Latin America, one in Asia, and one in Africa, to demonstrate how this can work and then hopefully be transferable also to other contexts. So for us, in fact, in a nutshell, the key ingredients for a successful partnership, and specifically a public-private partnership, is that it's co-created with the local authorities. That's the first condition sine qua non, that the local partners are the owners of the whole program. It has to be patient-centered. We've seen magnificent interventions fail because they didn't take into account the realities of patients living in slums. For example, in Nairobi, a perfectly implemented hypertension program increased the blood pressure control rate from 3% to 6%. Which is absolutely incredibly hard to believe, but it simply was because health-seeking behavior cannot take priority over job-seeking behavior in an urban slum. People have to survive first before they can spend their time and wait for a health provider to look at them. So we also believe that a successful partnership specifically for addressing non-communicable diseases such as cardiovascular disease require cross-sectoral but also multidisciplinary partners to have a holistic approach to address it. And obviously it needs to be built on evidence. Last but not least, besides all these ground interventions where we are generating the evidence of what can work in the field of urban health for cardiovascular care and cardiovascular prevention, we are also having some kind of a convening power at the Novartis Foundation. We love to organize this kind of events, dialogue events, where we discuss specific global health topics of interest in our work, and with several different types of stakeholders. And one of the last dialogue events we held last year was in London, together with the London School of Hygiene and Tropical Medicine, where also Joe was speaking about the age-friendly New York in our urban hypertension programs for all over the world. And this kind of dialogue will be repetitive. We are organizing a new one now in the second half of the year in Basel again. Basel is in Switzerland, for those of you who don't know, where I am working at the headquarters of Novartis. So thank you very much for your attention, and I really look forward to the insightful and inspiring discussions in this conference today and tomorrow. Thank you, Joe.
And our final speaker, and really our most generous supporter, is the Robert Wood Johnson Foundation. We were honored to be one of the early investments, I think, of Robert Wood Johnson for a very new global program. And they've funded essentially a track in this conference to really learn from each of you about ideas, global ideas for a U.S. solution. So Tracy Orleans, who is responsible for that program, is a senior scientist at Robert Wood Johnson and is taking the lead in this program. We're delighted to have her here. Tracy?
Okay, thank you. So to advance my slides, thank you. It's a pleasure to be here. Thanks everybody for being up so bright and early on a Sunday morning in this beautiful city that we're in. I'm here today to tell you about the Robert Wood Johnson Foundation's new mission and our new global mission, which is new to the foundation, and the new global funding that we will be making available. It's also been fascinating to hear the commonalities in our work from all the speakers this morning. So it truly is an honor to be here on behalf of the Robert Wood Johnson Foundation. And it's thrilling to be surrounded by national and global health and healthcare leaders, geographers, really exciting, and urbanists, because never before has the mission of the foundation and the work of the foundation converged so deeply with the work of the ICUH. And I'll explain what I mean by that in just a moment. So the power of place. In the 44 years of our existence, we've learned a great deal about the power of place, and it's really beautifully summarized in this one snapshot showing 6 to 8 year differences in life expectancy in communities 4 to 6 miles apart. This is our nation's capital, Washington, D.C., and maps like these have been presented for every major city, subway, metro system there is. And it speaks to the stark differences in healthy environments, access to health and health care, even where we would expect to have optimal health. We recognize, and this is our president, Risa Levizo-More, and vice president for research, Alonzo Plow. We recognize that health and well-being are greatly influenced by where we live, how we work, the soundness and safety of our surroundings, the strength and resilience of our families and communities. This seems like a new idea, but gee, if we look back to the Ottawa Charter, we can see that it's been on our radar screen for 30 years. Why has it taken so long for this paradigm shift? Paradigm shifts take a while, they take evidence, and we took a major leap last year in committing to work on building a culture of health for all Americans. This is our Culture of Health Action Framework. You know, it's late, and I'm not going to take time and do an explanation of these 4 sectors, but we developed the Culture of Health Action Model and Framework after interviewing and talking with and learning from over 1,000 U.S. and global leaders. And the question we asked is, what is holding our nation back in achieving optimal health? And the answers we got put us in touch with the need for making health a shared value, fostering cross-sectoral collaboration, creating healthier, more equitable communities, strengthening the integration of health services and systems, and adding something very essential to all of these activities, and that is a focus on health equity and also a focus on well-being, which is not a very U.S. focus to date. We've got a lot to learn from other countries about achieving well-being and shared value of health. I'm going to be presenting in a plenary later today. I'll have some extra copies of this booklet. You can download an explanation of our Culture of Health Action Model and Framework from our website. And I would recommend that if you are applying for an RWJF grant, you make explicit reference to that action model and to what you read here, because that will raise your potential for getting a grant significantly. So, what else do we have in common with ISHU? Well, we have in common that we are now embracing global learning. A little over 2 years ago, we launched the Foundation's first global team, which means that we now have the ability to give grants outside the U.S. When the goal is to incorporate learnings that will advance health in the U.S. That's in our charter. We cannot fail to bring lessons learned home, but we're increasingly exciting about the learning from other countries that's guiding our work now. We've done some really exciting work through our global grant-making effort to understand and study open streets and ciclovia initiatives that really have taken hold in Latin America and South America, and get families, communities up on the streets to get physical activity. But you know what else they're getting? They're getting that shared value of health, that sense of belonging in their community, that social connectedness that so many of us in these modern days are missing. It's vital to health and well-being. Olga Lucia Sarmiento is here today and will be presenting on this work as in our plenary right after lunch. And in Sweden, too, another example of global learning, roads and traffic planning have been redesigned with safety prioritized over speed or convenience. Planners have added pedestrian zones, safe crossing, barriers that separate cars from bikes. Another example where we can learn. Other areas where we've been doing global learning from other countries about the regulation of e-cigarettes. We evaluated the Mexico soda tax, and those results are now guiding efforts in 8 cities in the U.S. to argue for local soda taxes to prevent childhood obesity. And there are many other areas in which we are investing globally to learn for the U.S. And one of the things that I'm most interested in, and had a great breakfast conversation this morning with Ana Diaz-Rue and Olga Sarmiento, is healthy placemaking, creating healthy urban spaces that bring people together who ordinarily are not brought together. And we see this as potentially a door to that shared value of health. And you saw that in our Culture of Health Action Model. We see that as the mainspring for culture of health and for the work that we want to support. So we're pretty excited about that. Who's we? This is Karobia Charia. I'm really substituting for her today. She moved into a new home with her family in Philadelphia last week and was unable to be here. I bring you her warmest regards, and she brings a unique background to the foundation she was the global director for Ashoka. By the way, she also has worked at FHI 360. Many of us have. And Ashoka is a network of social entrepreneurs in 70 countries, putting their systems changes, ideas into practice worldwide. She's the director of our team, and she wishes she could be here. On behalf of all of us and on the global team, I also want to end here with a request that if you have ideas for global learning, that you check our website, and you'll find us at www.rwjf global work. And in your packets is a one-page, double-sided handout describing our new global funding initiative, providing grants in the range of $50,000 to $250,000 for ideas from other countries that would advance any or all of our culture of health action goals. And the due date for these proposals is May 31st. So if you are interested at all, please check this out. And I would be happy today while I'm here and tomorrow to interact with any of you, to give you feedback about ideas that you think, hey, maybe we should check out RWJF. And it's really a pleasure and a privilege here to be here with other funders, including Dr. Aerts. So my pleasure to be here. I look forward to learning from you. This is like a feast for me. It's so hard to pick which sessions to go to, but I'm thrilled to be here. Thank you very much.
Okay, we had your website in the next one. Yeah. Okay, thank you very much. Thanks to the terrific presentations from our earlier speakers. They've covered most of the teeing up of this session. So I want to invite our speakers to the table, Carlos Dora, Selene Guevarghese, and Erwin Lopez, if they could come up and join us. You're about to see a mixed media presentation. We have we wanted to spend this next a little while really drilling into both the SDGs and the habitat process from people who are in the midst of it. I'm missing, you've seen David? Sorry.
I'll get another seat over on this side.
Oh, okay. Oh, fine. That's a good idea. Yeah, just by way of background, this is by now a familiar slide, and a lot of our focus has been on number goal 11 and goal 3. I think he probably knows who he is, but just in case, yeah, you can turn it that way. Okay. So what we were planning to do with this session is we wanted to give a global perspective of habitat from Juan Clos. He was not able to join us, but we have him by video that was created for this conference, brief video, and then we're happy to have Owen Lopez here, who is a special policy advisor at the Habitat Secretariat, who will make some brief comments after the video of Dr. Clos. Then we're going to have Celine Gevarghese, who's really leading the Department of Housing and Urban Development work, which is leading the National Committee for the United States. So we wanted to hear what's the vision globally.
I would like to thank the organizers of the Conference of Urban Health, the invitation and the occasion that you are giving me to address you briefly on this issue of urbanization and health. This is a very important issue. It has been always very important in urbanization. We just need to remember that in the 19th century, the beginning of urbanization, the science of urbanization, was linked to the issues of urban health, was totally intimately linked with urban health and the hygienic movement. Now in the 21st century, things are different, fortunately. In many parts of the world, the basic issues of hygiene and health in relation to sewage, clean water, etc., it's more or less addressed. It's not the case in many parts of the developing world where this is still a problem, but also we have a new emerging problems. And the new emerging problems, of course, are the new threats to urban health related with contamination, air pollution, which is contributing to many problems of health in many parts of the world, including increase of mortality in cardiovascular disease, asthma, and other ailments that all of you know. Then the question comes, what are the new challenges of urbanization in relation to health? And we are extremely interested in this topic because in the preparation of Habitat 3, the big conference that this year is going to take place in Quito, we want that issue to be one of the important pillars of the debate, as it represents one of the big challenges of the future of urbanization. In that sense, of course, this is extremely related to the current manner of urbanization that we have around the world, the issues of climate change, the emissions related to all the different aspects of the greenhouse gas emissions, but also the particles and other problems associated with density and traffic, etc. And I think that all that requires a rethinking of the urban pattern, a rethinking that needs to address these issues. Of course, in itself, through the climate change policies, and hopefully after the agreement of Paris, of the meeting of COP21, we are going to begin this process of reducing the emission of greenhouse gases and then attenuating the effects of climate change. Hopefully that is going to happen as soon as possible, but also apart from that being addressed, still it remains in the urbanization part. How can we build a city that it provides the needs of the population in terms of also mobility, economic prosperity, quality of life, in general, jobs and opportunities for everybody, and it's compatible with a healthy city, with the concept of a pleasant way of life. I hope that your ideas in the debate that you are hosting in San Francisco, it's going to be a substantive, interesting contribution to the debates of Habitat 3. We are in need of changing the paradigm of urbanization. The current model of urbanization, we know that it doesn't serve the purpose. It's insufficient in terms of capacity to address the climate change issues and the health issues, the new problems of health, that means that we need to change it. And in that change, in this process of change, which is going to be complex because urbanization, it's a very heavyweight economic structure that in order to change its direction, it requires very strong forces in its change of direction. I hope then that the arguments and the quality of the reasons provided to change the current direction are going to be sufficiently shared and sufficiently strong in order to mobilize stakeholders in urbanization and also decision makers in order to really advance in a change of the current model of urbanization. Thank you very much.
Now invite Erwin Gabriel Lopez, who's an urban planner from the Philippines and is a policy unit officer with Habitat 3 to comment and elaborate a bit on Dr. Kloss's remarks.
Good morning, everyone. Just heard Dr. John Kloss, who is a medical doctor before he became the mayor of Barcelona and before he became the ED of UN Habitat. For now, he is also Secretary General of the Habitat 3 conference, which I will be explaining in this presentation. What is Habitat 3? It is the UN Conference on Housing and Sustainable Urban Development towards a new urban agenda. It happens only every 20 years. There was one in Vancouver in '76. There's one in Istanbul in '96, and there will be one 2016 in Quito. It is not just one conference, of course. It's a long road to Quito. It's a Habitat 3 process that includes regional meetings, thematic meetings, policy units, General Assembly of Partners, and others. You can refer to the link here if you take a photo and learn about the details. Okay, I would like to focus on 3 aspects of the process, which is the regional meetings, the thematic meetings, and the policy units. Most of the outputs here are already available online. They've already been discussed, and this will be the inputs towards the zero draft document, which will be the input towards the new urban agenda in Quito. For the regional meeting, we have four regions: Asia Pacific, we have Africa, we have Europe, and there will be one in Latin America and the Caribbean this month in Toluca, Mexico. The dates are there as well. 7 thematic meetings: civic engagement, metropolitan areas, intermediate cities, sustainable energy, financing urban development. And for tomorrow, there will be one in Barcelona on public spaces, and there will be one on Thursday in Pretoria, South Africa. Also, the third process is the policy units. There are 10. It's composed of 20 experts and 2 co-lead organizations with balanced representation according to region, gender, and grassroots. So these are the 10 policy units. Number 8 is very relevant for this forum. It deals with urban ecology and resilience. I browsed through quickly the Global Report on Urban Health and also referred to ICUH's framework on making cities healthier worldwide. So there are some similarities, and we can probably have the collaboration, especially on housing, design, and urban governance. So there is a very good opportunity here for collaboration already. These are some photos of the expert group meetings where the policy papers were discussed. They are not just there for, they are there physically, but we also provided opportunities for online participation, as you can see in the top photo. I think the gist of this presentation would be this question: what do the regional meetings, thematic meetings, and policy papers say about urban health? There's a lot, actually. Regional meetings have regional declarations. For example, in Prague, the Prague Declaration established the link with housing and health. So it says that poor housing conditions have direct effect on physical and mental health of the population. Also, it deals with the basic services. For Europe, just focus on the circle there. It deals with healthcare, education, and personal security. And for Africa, basic services was also discussed, but it's a different field. It discusses clean water, sanitation, energy, health, education, etc., which Dr. Kloss in his speech a while ago, he mentioned the differences with concerns and needs across each region. So this is also evident in the declarations. Also for Africa, they are dealing with air pollution, which is linked directly with health risks. For thematic declarations, the Montreal Declaration recognizes the accelerated urban growth may lead to health degradation. The Tel Aviv Declaration, on the other hand, establishes the need to reduce the negative impacts of urban activities and of chemicals which are hazardous for human health and the environment. This is very interesting for Abu Dhabi. It shows how the benefits of health encourages the use of clean energy. For policy papers, these are more detailed discussions on urban health and different topics as I showed a while ago. Policy paper 8 mentions this quote: human health and natural systems are intertwined. Human health and natural systems are intertwined. It deals with wastewater, air quality, especially with coal, pollution, food security, and clean water at the same time. There's a need to optimize urban subsystems and health systems, and human health, through effective management for urban environmental sustainability and resilience, is according to Policy Unit 8. There's a need to invest in infrastructure and public spaces, targeting water quality, water resource management, minimizing pollution, open spaces, etc. Also, there's a big concern here about access. It's not just the presence of infrastructure in public spaces, but also the access of people so they can use it. In terms of housing, sanitation, and transportation, I will just read this quote very quickly. Without such access, not only will the well-being of city residents suffer, but cities will fail to meet their potential as national engines of economic growth. Policy Unit 1 mentions this, that cities must ensure that basic services and infrastructure are, number one, physically accessible, affordable to all, culturally adapted, non-discriminate, and safe for use of all. For other recommendations, it deals with policies and zoning, funding, empowerment, data for monitoring and analysis. It's a very common thing across all policy papers. Social protection systems and housing as well. Okay, it's clear among the paper and the declarations that urban health is a cross-cutting issue across regions, across teams, across policies, and across different urban dimensions. From now, so what will be next for Habitat 3? In a few weeks, there will be an open-ended consultative meeting in New York, which will present the thematic declarations, the regional declarations, and the policy papers to member states. There will also be informal hearings with local authorities, intergovernmental meetings, informal hearings with stakeholders, and others, leading towards the Surabaya Prep Committee and then the Habitat 3 Conference in Quito. This is my last slide. This is how can urban health advocates participate. You can do so through the GAP. The president of the General Assembly of Partners is here with us, Ms. Eugenie Birch, who's sitting in the second row over there. If you have questions on the GAP, she will be presenting again tomorrow in the plenary session. So I hope you can attend. This is a good way for you to collaborate with Habitat 3 process. And there are 15 partner constituent groups. And you can just take a photo very quickly about the link, so you can refer to it later on. Thank you so much.
I'm happy to say that Jeannie Birch is a member of the board of the International Society for Urban Health. We're delighted at that connection as well. Our next speaker, Sylid Gavarghese, is a Deputy Assistant Secretary for the Office of Policy Development and Research at the U.S. Department of Housing and Urban Development, and is really leading the U.S. platform for Habitat and the SDGs. We're delighted to have him with us. Thanks.
Thank you. It's a scary notion that I would be leading something. Thank you, Dr. Boufford, for your leadership and for the invitation to speak today about the U.S. preparations for Habitat 3. It's a pleasure to join you at the 13th International Conference on Urban Health. I confess that I'm here as a health professional only by association, given that nearly every member of my family tree is a medical professional or a health professional or an academic or researcher. And I don't know if that counts for anything in this audience, Many of them, in fact, asked me when they heard that I was going to be coming to this conference with a little bit of a tone of envy, why are you, Salin, from the U.S. Department of Housing and Urban Development, talking at a conference on urban health? I would argue that we are here today, joined together because of the shared results we seek for people and places. Some, like myself, are animated by issues of equity and access to opportunity that have been spoken about already, and the social determinants of health. We bring different tools and expertise. We talked about the paradigm shift and the slow roll toward that paradigm shift in solving these challenges in a shared enterprise. The Habitat Conference, as Erwin talked about, happens only every 20 years and are among the largest convenings focused on urbanization and sustainable development in its broadest formulation, and equity and access to opportunity for all. All of our speakers today would suggest to you that if you haven't clued into Habitat 3, if there is an objective for us, it's for you to clue into Habitat 3. Given that shared enterprise in the opening statement by Dr. Close and Habitat 3 and the theory around urbanization and health and that history, let me share with you about, as Joe has mentioned, about how the U.S. itself is preparing for Habitat 3. Since the summer of 2014, the U.S. government has been engaged in our preparations for Habitat 3. Under the leadership of Secretary Castro at HUD and Secretary Kerry at the U.S. Department of State, we have undertaken a broad and inclusive process to raise up our lessons learned over the last 20 years since Istanbul, create a platform for voices and actors to engage across sectors, across silos and disciplines, to inform our story and our priorities, and in particular, to pivot to the future for the next 20 years. We do this by focusing on several key objectives. Joe mentioned the U.S. National Committee. So we've created an infrastructure of partners and voices with that U.S. National Committee and 3 subcommittees focused on education and outreach, on connecting the U.S. to global conversations, on how it is that we are going to be distilling our lessons learned in the national report. For those here from the United States, how many here from the United States? I figured I should get some hands raising. It'll encourage that with your caffeine to stay awake. There are a number of you from the U.S. Last year, in fact, this month, the U.S. submitted its response to a set of questions from UN Habitat across a range of themes. Our preliminary draft national report, and we're going to be producing over the next couple of months an additional publication in our own voice, informed by stakeholders with our own themes. We are also taking, and I think this is really important for other representatives from member states and other organizations, we're taking the conversation about Habitat 3 out of Washington, D.C. and out of the United Nations in New York City to sponsor a set of regional domestic convenings, the first of which actually was last Thursday in Chicago. And in fact, Jeannie, who has been referred to earlier, is helping us pull off a second one in Philadelphia. There will be one in Miami. There will be another in Denver. There will be a 5th in El Paso, Texas. Why is that important for us in the United States? It's important not only for what you might assume, for the conversations to get out of the often rarefied policy context of Washington, D.C., out into the field, out into communities, informed by local policy and practice, and that, in fact, is what is happening with those. Lastly, we are hosting 5 policy convenings in D.C., in fact, focused in particular on the foreign policy community, which often, as I might say, comes in and out of thinking about why should we focus on cities. We have numbers of conversations with our colleagues who are in foreign policy considerations and priorities, who will say exactly what's happening in the country, but actually don't know what's happening in the city in which they are located. So important for us in the policy convenings in DC to connect foreign policy to the city. Each opportunity is present for us in the US to engage more voices on urbanization, sustainable development, and the opportunities and challenges of our cities. And we're hopeful that going forward into Quito, Ecuador in October of this year, that we will be able to tell ourselves what lies ahead for 2016. I want to pivot real quickly. I'll try to do it real quickly. I know we're behind. Let me close with a little bit of an examination today about and some of the abstracts that I know have been presented, and not needing to convince you about cities and urban environments existing as the laboratory for public problem solving across a number of dimensions. I invite you to think about cities as more than the target geographic scale for an intervention, the place where your work comes together for better health. Yes, we know here in the United States and across the world that hotspot applications that will enable us to target neighborhoods where there are multiple users across systems makes a difference. We see that work powerfully demonstrated in a place like Camden, New Jersey. I invite you to think about where cities and built environment interventions are levers for better health outcomes. From the work of healthy home interventions that dramatically reduce asthma triggers in a home and lead exposures in a place like Baltimore, to work that stems from health impact assessments that all of you know that will focus communities on addressing the social determinants of health and poverty here in the Bay Area and in Denver and across the country, to developing policy and budget structures, one can only hope, that help us address our wrong pockets challenges in DC and Tokyo, where if a health intervention has a positive health consequence, how might we recognize that from a budget perspective, where now it is thought of separately? We need to see each other in each other's work, regardless of where the chosen frame or jargon is present. Affordable housing provision, we all know, is not just about shelter. You only need to walk a couple of blocks in San Francisco from here and see where we know that permanent supportive housing interventions that help us address homelessness are about more than getting individuals off the street. Housing stability, as has been said repeatedly, is inextricably linked to addressing mental and physical health challenges, as we know in the Mayor's Challenge on ending chronic veteran homelessness. It need not be that housing is left to the housers and the community development professionals, that education achievement is left to the educators, and health is left to the health professionals. Although my family members would say, leave it to them. We need more data and evidence for better program design and policy development. We need greater commitment to shared learning across silos, disciplines, sectoral interests. We need to come together, and Habitat 3 provides that venue for a focus on cities, sustainable development, poverty alleviation, and access to opportunity. Perhaps more partners like all of you and collaborators will come together with their resources to solve problems over the next 20 years as we move to Habitat 4. That's my invitation to you today, to continue to stay engaged on urban health in all of its manifestations, especially at Habitat 3. Refuse to stay on the sidelines to assign this work to someone else. For us to make progress in all of our cities, for all of our people, it's all of our jobs. So I thank you.
And now to sort of pull it all together from the urban health perspective on habitat and SDGs, we're very fortunate to have Carlos Dora, who is coordinator of the Public Health, Environmental, and Social Determinants of Health Department of WHO in Geneva. He's a health policy expert and has been very active in looking at the health impacts of sector policies in energy, transportation, housing, extractive industries, and his work on health and the green economy is really analyzing health co-benefits of climate change mitigation. So we're delighted to have him here, and you can sort of pull it all together for us, Carlos, on the urban health agenda.
Excellent. Yes, please. Well, thank you very much. Very pleased to be here. Thank you for HUD. I mean, you may remember this, but we've been doing lots of work on healthy housing with your support, which we gratefully acknowledge. It's been very important to, in the reflection of how is it that we as a public health community can contribute to this agenda. And I'll start by addressing some of the comments from Dr. Close. I think he pointed the finger at air pollution and climate change, and I think he's right in that those open there's new things there which are really challenges that we have to respond to. And I think I'll orchestrate and organize the response in terms of what do I see in Habitat 3 papers, which is not necessarily the same thing as you see, because I come from a lot of public health knowledge or experience, and so does the community here. So I think I'll bring some of those points. And I'll argue, I think, why is it that the community of public health should articulate and should engage in a much stronger way. And I'm 100% with you. I think that's a huge opportunity for us to be much more present and to articulate our proposed response and share our understanding, our knowledge in a way which is bigger than perhaps we have done so far. We've been trying different ways. And I'll base that on the strengths that we have in public health and health system. And I'll end up with an idea of what is the new urban health agenda for 2030, which I think we have to be thinking those terms, because it's not only UN Habitat which is doing this. This is a collective effort. Cities are, 70% of the CO2 emissions, of the budgets, or the GDP of nations, is more than half of the population. I think, of course, the leadership of UN Habitat is essential, but we all have a role to play, and we cannot expect that they are going to do it for us. So I'll articulate in those terms. And I chose that, there's many icons for UN Habitat. I chose that one because there's so many interests going, hopefully, in the same direction. But I think making sense of all that, and that the fact is, how do we put people at the center, as I think Novartis was just saying before. I mean, how do we, they acknowledge that people are at the center, but, how is it that we make that a reality? And I've just been to one of the meetings. I think some countries asked me, can you please come here and put some health in this discussion? And I sort of dutifully, I did go. And my reading of that, we didn't manage to do much health in the discussion. But so I think, why is it that we perhaps have this different perspective? And I think it's the way we expect, considering our knowledge and experience in public health, and what we know about cities and how they determine health, I think we can do a lot more. And that's why perhaps the different readings about what's in the policy paper, which I read carefully. And I'm writing a little note with colleagues in WHO to send you, how is it that we see that we could see that better articulated as one of the cogwheels that would allow for this healthy urban and human-centered development to take place. Why do we bother so much? Why do we feel so strongly? Why I'm so committed, and we are also committed for this? One is because I think we know there's a lot of evidence on the health impacts of public policies or housing, of transportation, land use planning. that should be taken into account in all the policy decisions. And they're not necessarily there because there's a lot of knowledge which is just, there's just too much. So how is it that we can make use of that so we can make better use of resources? It's very unfortunate if you're making a decision on housing for weatherizing a home, and then you're not thinking of ventilation, you're not thinking of radon or, VOCs, and then you end up with a result that is not what you're expecting. And you can only do that decision wisely and make a good investment if you really know what are the kinds of issues that you have to deal with. How do we facilitate engagement around the issues of land use planning and economic debates? I think because we work with the health dimension of it, we allow that's a more easier currency for people to understand. So this is what it will mean for you, it's going to mean for your child, for your neighbor, for your family. And I think that's something that the health sector can do, or the health system, the health experts can do especially well. How is it that we should be interfacing with Habitat 3? And I think is on the mechanisms for implementation. It's all very well that we're there, it's important, etc. Yes, that's in the preamble, it should be. But we also need to see that reflected in how actions are going to be taken, and how is it that we can then contribute to that, the agendas as they are getting implemented, and what specifically we can contribute. And we can contribute, and you organize a lot of the debates around planning, finance, governance, and indicators, and that's why I just give you a few brief examples of what is that we have. You mentioned health impact assessments, we do have. For planning, any plan in a city should have a health impact assessment ex ante, so you can, when you're financing those things and you're talking with the bank about your investment plan for your city, you can anticipate risks, you can mitigate those risks, and you can ensure that your financial plan is sound on the basis of, and you're not creating externalities. And if you analyze any analysis of externalities, you would know that over 70, 80% of the externalities are due to health impacts. So if you're not looking at that, and you're making a business plan for housing, for transportation, without looking at those externalities, then you very likely will get it wrong. So I think that's a financial reason. In the governance mechanism, there's a whole question of participation and engagement of different groups of the population, how is it that they can contribute. And on tracking progress, rarely other groups in society have so much data as health people have. And we were so data rich that, I think we have to make that resource available to this urban discussion. And so I'll give you some examples of what we're doing in terms of climate change and air pollution, because there are new things which are coming up. But I think whatever we're doing, we're building on a very large legacy and experience in working with urban settings, etc. You've just seen today the report, or a couple of days ago, that the Cubby Center developed jointly with Habitat. WHO is now reporting on diseases on the basis of the SDGs, which is very interesting. Now I can report to my member states how we are faring in terms of health impacts of energy, or health impacts or energy efficiency, for example, or access to, so it creates a different dynamic in terms of how we establish a conversation with our member states and our ministers of health. And this is the first report of those. The second one is coming now at the World Health Assembly in May. Healthy Cities has done enormous amount of work, and it still does. So I think there are models for, and I'll put just an example of a report that we produced recently about short-lived climate pollutants and health impacts, and where are the best buys for, where's the evidence for intervention. So we're full of knowledge that I think has to be shared. The tools that we discussed, including a lot of scenario analysis in this conference over the last day on geography, touched a lot on that. Indicators rich, experience a lot, very extensive. And the health sector is also present in every city, which is not the case with the environmentalists, for example. There's no environmental service in every city in the world. But you go to a poor city and you'll find a health system. So the fact that we are very organized in the way that through our scientific synthesis, we decide what are the best ideas to treat malaria, to, including to what's good housing, what's healthy housing. And that's an advantage, because we have a way of communicating with every village or every city in the world about issues like this. Now, we haven't done that, but that's not to say that we shouldn't be doing. And that's, I think that's exactly where we should go. I have, how many minutes I have? 3. So I'll just say that what's new in global terms, that we're doing a lot of work on air pollution, and you'll see there's a very large global campaign on communication about this, partly because we have been very silent about this, curiously. I mean, we have, over the last 15 years, learned that air pollution causes vascular disease, strokes, and heart disease, which we didn't know before. So there's enormous amount of, it's not only lungs. I mean, I thought I would bring some blood and flesh to you, just, you know, being a good doctor. It's always healthy to see where does the pollution end up, really. And one lung gets tobacco, the other one is air pollution. And they have the similar kind of pathology, in fact, physiopathology. But we know that NCDs is the big cause of that. What do we do in that air pollution is responsible for at least 1/5 of those deaths. But our programs in public health don't yet touch air pollution. So although we feel comfortable to work with other sectors in tobacco, in physical activity, we haven't yet done that. And I think we should be doing that. So I won't go, these are just evidence that we get together around the cancer and vascular disease, et cetera. I won't go there. We've been sort of putting together evidence on exposure, borrowing from NASA and from people who do satellites, who do the monitoring, emission inventory, and source apportionment, you name it. We created a global platform that brings it all together. We have a global database on air pollution in cities. New York data is coming up next month. And we come up with some estimates of burden of disease and overall 7 million deaths. You know what? That's the same as tobacco. Now, that's a lot of deaths. And for a health sector who has been doing, I wouldn't say nothing, because we have been doing guidance of what's clean air and what's good for health. But in terms of interventions to prevent this, the health sector has not mobilized yet. So, I mean, the health ministers got very worried. A year ago, so just details of what that's, there was a World Health Assembly resolution that said, well, we got to move on that. And what does it say? We know it's not our sector primarily who's causing it, but we have to work with others. We have models for health in our policies. What is the role of health authorities to address and to prevent those diseases? So basically the decision was made. There's a very extensive resolution. We're coming up with a roadmap. And in the development of the roadmap of the executive board this year, they asked specifically that we make very explicit the connections with SDGs and with climate change, with the COP21 decisions. And that's exactly where we're going. So I won't go into what we have in terms of resources, and I think we have guidance and a lot of evidence on health impacts of other policies. Some of it is systematic review, some of it is policy analysis, examples of what sectors, how much you can get out of each sector in terms of reducing burden of disease. Tools, for example, this is a tool which is used very much, cost-benefit analysis of urban interventions in transportation, or cycling and walking, pedestrian areas, etc., tracking mechanisms, and action research, as well as communication. So what we're piloting, and I'll close with that, is work with some cities, and we're starting with implementation in Africa, in African cities, where we bring the sources of air pollution and climate pollutants, and they are most sector policies. Agriculture produces a lot of ammonia, and it's one of the major causes of air pollution in Europe, for example, is ammonia and methane. It's half the air pollution deaths in the UK are due to agricultural policies, so you wouldn't expect them. So to bring those policies and identify which are the policies that reduce climate pollutants, which reduce air pollutants, that produce most co-benefits. And that is reduce injuries, increase physical activity, reduce noise, increase social interaction, and a more inclusive, and a more, so respect the needs of people with disabilities, of children, pregnant women, etc. So is that over a holistic model? Although we're starting with climate and air pollutants, we come with the solutions, they have to be holistic solutions. And we're piloting this model in building capacity for cities in Africa initially to actually do this analysis. Because we want people to be able to get hold of the data in their city, see what opportunities, what are the main problems in that city. Lagos is waste management, big waste dumps, burning, chemicals. So that's the main cause of some of this. So in Lagos, what we're going to do, we're going to work with the locals to get hold of the local data to inform what are the policies that they have, options that they have, how much they will afford or bring in terms of benefits for the local population, and share that with the local politicians, with the different stakeholders, et cetera. And sharing also with the development banks when they're going to invest in waste management, transportation, et cetera, how is it that they can take into account those. So that model is starting. We're very excited, and we're very grateful, especially for the sort of all the work that has been going on health and health policies, health intersectoral action that we've had in WHO and elsewhere. And I think this community of urban health actors, and I'm saying actors, it's not only academics, I think is what we want to mobilize. I think it's a very good timing for that. And we really would like to see an urban health agenda for the year 2030 that contributes to UN Habitat 3, but doesn't wait on Habitat 3 to tell us what to do, because I think we have a very good idea of what to do. And I think we're happy to make the contribution that way. Thank you.
In the interest of time, we will make Dr. Poonam Singh's message part of the record. We're being videoing this plenary, so we'll include it. Suffice it to say that she's been a strong stalwart. She attended a meeting in September with the UN and has been a really strong advocate for advancing urban health in the Sira region. I do want to sort of end the meeting. We don't have time for questions, I'm sorry, but happily folks are going to be around, so I know you can corner them and ask them their questions and talk about it. I hope you've gotten a sense of the really important opportunities that our fantastic speakers have given you in the global arena, but also, as Carlos said recently, as we move into implementation in countries, as Celine said, even in the United States, in the high-income countries, SDGs applies to them and Habitat applies to them. The MDGs did not, and that's a big shift. So we have a real opportunity to pull together interdisciplinary, intersectoral, and we look forward to having ICUH work with all of you to really make the emphasis on urban health in its fullest sense a reality. Let me just take one more minute by inviting a colleague up to the desk. We were a little concerned some people may be peeling off late today and first thing and tomorrow. We hope not. But we did want to invite Angela Freitas, who is representative of the University of Coimbra, who has a very nice announcement to make about the International Conference on Urban Health in 2017. Just take a minute. David, just going to put her the slides. She's putting
on. Hello, everyone. It's an honor and a pleasure to be here representing University of Coimbra, and Paula Santana, who sent warm regards to all participants, and it is very pleased to welcome you on the next year on Coimbra, city of Coimbra, Portugal, that will host the next International Conference on Urban Health. The University of Coimbra is one of the oldest universities of the world and one of the top 10 beautiful campuses. So we are very pleased to welcome you to visit us. The venue will be located in a nice building, old century, is the convent of St. Francis, and it's now transformed in a nice congress building. The city is really nice, and we have a good weather, good food, good wine, and we It's important to eat well for our health. So, looking forward to see you next year in Coimbra. Obrigada. Thank you.
See, we're very excited, and it's interesting, wasn't planned ahead of time particularly, but the Department of Geography at the university is hosting the international conference, so we hope to continue the connection with Doug Richardson and our geography colleagues. And I want to also acknowledge Elsevier's engagement in helping us really move this along, and we're very pleased that they'll be an ongoing partner in helping us to produce the conference in 2017. So the business meeting for ISUH is at 6:15, immediately following the final plenary in the Monterey room right across the hall. We'll be announcing that at the end of each of the plenaries. Anyone who's interested in what we're doing in more depth and also in our work is invited to come. And again, thanks for a very rich session. I'm sorry we didn't have time to answer questions, but you've provoked everyone to come at you very vigorously over the next day. So thank you very much, and we'll take a brief break.
Over half of the world's population now lives in an urban area. This global trend is deeply affecting WHO's Southeast Asia region. In 1990, 26% of the region's population lived in urban areas, but by 2015, that proportion has grown to 37%. Southeast Asia is now home to several of the world's largest megacities, including Dhaka in Bangladesh, New Delhi in India, and Bangkok in Thailand. Along with urbanization, lifestyles have changed and demographics have shifted. In turn, the services that cities offer to their residents are being adapted. Health systems, too, must be responsive. Not only must health systems adapt to the scale of 21st century urban living, they must also meet the emerging health hazards that unplanned, unsustainable development provides. WHO's Healthy Cities approach is essential to tackling these problems. The Healthy Cities approach seeks to put public health high on the political and social agenda of cities and to build a strong movement for public health at the local level across all sectors. It is, after all, only through multi-sectoral action that these vast issues can be addressed. The Healthy Cities approach is having an impact across the region. In India, for example, the government's Swachh Bharat or Clean India campaign has resulted in 273 districts from 23 states implementing clean city plans. These plans enhance waste management, increase access to sanitation facilities, and affect behavioral change. In Thailand's capital, Bangkok, the Metropolitan Administration has implemented the Healthy Bangkok Plan, which includes policies for improving housing for the poor, poverty eradication, and environmental management. The administration also upgraded hospitals and health centers in the city, which is Asia's 9th largest. But the benefits aren't confined to the megacities. Smaller towns and cities are also finding that good planning is the best way to enhance public health. At the same time, across Indonesia, local governments are financing healthy living initiatives such as sports and health clubs in line with healthy city guidelines. All of this is immensely encouraging. Though the Southeast Asia region has its share of health-related challenges resulting from urbanization, there is a clear region-wide resolve to tackle them. WHO remains committed to supporting these efforts through advocacy, technical guidance, and practical support. We will continue to help countries in the region increase access to safe drinking water and sanitation in cities. We will go on assisting them to combat outdoor and household air pollution. And we will stay the course in backing projects to tackle urban poverty and its health-related outcomes. This is WHO's commitment, and we will fulfill it until every city in the region is a healthy city. I wish this conference all success. Thank you.